All right. So hopefully everybody can see me okay. I have the privilege of introducing Dr. Pierre De Delva today, and he's going to be giving us a talk on some of the specifics of what esophagectomy is and where we kind of stand today with patient selection of who benefits and how we do it, and where it should be done. He actually comes to us from a fairly select pedigree. He went to Mass General for thoracic and general surgery training before doing an advanced fellowship at UPitt. And certainly I've had the privilege of doing minimally invasive esophagectomies with Dr. De Delva, and that's where I got my start too. And so I'm excited to hear about some of the things that have come along since I have graduated. So looking forward to hearing it.
Great. Thanks for the introduction, Tyrone, and welcome to everybody. My pleasure to be talking to you today about esophagectomy. As I was thinking about the topic, I thought that it was going to be kind of hard to figure out exactly how to tailor this, because I know we have a lot of different participants in the discussion. We have gastroenterologists. We have I see one of our applicants to our training program. We have our recent graduate, and so I figured though that esophagectomy is really kind of a big term that captures a lot of different operations, and probably if you hadn't trained in thoracic surgery, it's probably really confusing. And so I thought it'd be good to kind of go through the framework of the operation, how it's done, and some factors that I think can help everybody that either does a surgery or has patients that have esophageal problems that need resection. We'll mainly be focusing on the cancer piece, since that's what we've been hitting in the series lately, but I'm happy to take some questions about benign disease as well. So we'll go through the principles and objectives of esophagectomy, the indications, the type of esophageal resections, and why we choose certain operations versus others, our adjuncts to reconstruction, and I'll explain that a little bit, complications and outcomes. So what is an esophagectomy for cancer? Very simply, it's a removal of the esophagus. Some percentage of it is usually greater than 50%, most of the time 75%, sometimes a near total esophagectomy. It requires an adequate nodal dissection. Then we have to reconstruct with what we call a neoesophagus or a conduit, some way to reestablish the swallowing circuit. And usually that involves an organ transfer, very similar to a muscle flap, having to rely on some blood supply or some augmentation of blood supply to have the organ be able to survive in a new cavity. It involves 1, 2, or sometimes 3 anastomoses or new connections, which all have to heal. And unfortunately, in the esophagus, when you take into account the margins and usually the size of tumors, an end-to-end esophageal anastomosis is not feasible. And I don't know that a lot of non-surgeons understand that piece of it. It's just very hard to, like in the colon or in the small bowel, to do an end-to-end anastomosis in the esophagus. Our goals, so our operative goals, or what we would consider a high-quality esophagectomy, would involve complete resection of the tumor with margins. And usually those proximal and distal margins, generally we say 5 centimeters. There's some circumstances in which we accept 2. It's variable, but in general, we try to achieve a 5 centimeter margin, and as well as a radial margin. And the radial margin means the circumference around the esophagus. There is some debate about exactly what a radial margin is and if one exists in esophagectomy, but there is some data that if you have less than 1 millimeter of radial margin, that the outcomes are not as good. And the radial margin in particular is where induction chemoradiotherapy can really help us be successful. Quality measures indicate that at least 15 regional lymph nodes are associated with better outcomes. And we think that that's probably related to better staging and understanding of where patients' disease is really. And in fact, if you harvest less than 15 lymph nodes, that's an incomplete staging according to AJCCC staging guidelines. So for those of you that are non-surgeons that are evaluating the quality of the esophagectomies you're getting, a good regional lymph node dissection is a good way to measure your surgeon. We want to have a reconstruction with a functional swallowing mechanism. Obviously, low morbidity, good quality of life, and oncologic cure. Those are our goals when we go into the operating room every time. Now, as I started thinking about all the ways that we can do an esophagectomy, and actually try to do the math to figure out how many combinations there could be, I think it's somewhere around 40,000 different combinations of operations that you could have. But I'm not a mathematician, so I could be wrong, but there are over 6 or 7, and I think I was being conservative, type of esophageal resections. There's different approaches, whether it's MIS, robotic, hand-assisted, hybrid, 1 incision open, 1 laparoscopic. What you do with the pylorus, what you do with the jejunum, do you use the omentum, what kind of lymphadenectomy you do, what anastomotic technique you use, the conduit. There are really a lot of variations. And so to me, as I think about it as a surgeon trained in general surgery and cardiothoracic surgery, I think esophagectomy is one of the least standardized operations in history. There are so many variables here, and you could talk to 100 surgeons and you would get a lot of different answers of why I do one of these categories versus the other. So I would imagine that for a non-thoracic surgeon or non-esophageal surgeon, it could be really confusing and probably difficult to understand. Now, we've come a long way though, despite all that variability. We've come a long way from Dr. Torik's operation of removing the esophagus and putting a plastic tube to bypass, to establish swallowing mechanism, to today where we can actually, do this operation minimally invasively. This is an example of the steps that we take when we're going to do an anastomosis. This is a completely intercorporeal small incision operation, which 15 years ago, 20 years ago probably would seem impossible. Maybe 10 or 15 years was limited to certain centers of excellence, and now has become more and more prevalent throughout the country. So quickly, just reviewing the indications for esophagectomy. The benign categories are usually related to really bad problems that are recalcitrant to medical management, or limited surgical operations such as end-stage achalasia, failed anti-reflux surgery, recalcitrant strictures, caustic injuries of the esophagus, and bad esophageal perforations. In cancer, the management of esophageal cancer and high-grade dysplasia with Barrett's has really changed the role of esophagectomy in the early stage cancers. And Dr. Mormon has done a couple of our previous series on the role of endoscopic therapy, so I won't go into it too much, but just to say that there are patients with mucosal disease that are not ideally treated by endoscopic techniques, in which esophagectomy still has a role. And those include patients with submucosal involvement or deeper, and there's some debate about that. Poor histologic grade, lymphovascular invasion, patients with long segment or multifocal high-grade dysplasia that can't be completely eradicated, and patients that had a suboptimal EMR and ESD, depending on margins, depths, and things like that. So clearly anybody with mucosal disease, with nodal disease, is a better candidate for esophagectomy or chemoradiotherapy. And bulky tumors typically end up undergoing surgery if resectable. Now I wanted to take a second for the go through the surgical anatomy, because I think it'll help to understand some of the challenges that we face in esophagectomy and the complications that sometimes arise. So the esophagus is a muscular tube that originates at the cricopharyngeus, at the upper esophageal sphincter, and extends down to about 40 centimeters. And in general, the more proximal the tumor is, the more difficult it is for us to treat it. And I'll explain that in a minute, but for example, tumors that are in the neck are typically very difficult to treat. They're typically squamous cell cancers, and for the most part are treated with chemoradiotherapy and only surgery in a salvage setting, meaning if they recur, they have persistent disease. And even when we operate on those patients, the oncological and functional outcomes are pretty tough. As we keep going down from the upper thoracic to the middle thoracic to the lower thoracic, the operation has less morbidity, and we have more options in the treatment, surgical and as well as chemoradiotherapy. It's important to recognize that for the roll esophagectomy, the issue with depth of invasion is related to the histologic anatomy of the esophagus. And the issue arises that the lymphatic channels are right at the level of the submucosa. So as the tumor increases from a T1 to a T2 to a T3, the chances of nodal metastasis grow up dramatically, from less than 5% for a T1A lesion to over 75% in a T3 lesion. So as depth of invasion increases, the chances of nodal metastasis is higher, and so that's where perhaps a T1B or a T2A lesion would be more amenable to esophagectomy, and it is more amenable and better treated with esophagectomy because of the risk of nodal metastasis. And so again, you see that depth of invasion, and as you get deeper and deeper, you start encountering the lymphatics and the potential for lymphatic metastasis. So another important thing to understand is the issue, some anatomy with the stomach. The stomach is our favorite organ for reconstruction of the esophagus, or a conduit. An important thing to recognize is that when we move the esophagus from the abdomen to the chest, we have to separate the upper part of the esophagus from its native blood supply. We also, most of the time, have to separate the nerves as well. And so this part of the stomach can become ischemic, and protecting this part of the stomach is critical. Particularly the higher we go, the more we rely on the part of the stomach that is ischemic to heal and function. And when we divide these nerves, we basically are doing a vagotomy in the stomach, which essentially can lead to delayed gastric emptying. The issue of blood supply also applies to how we build the conduit. Some people like to use the whole stomach. Some people like to tubularize the stomach, because as you tubularize it, you increase the length and perhaps a better functional outcome. But the blood supply is dependent upon collateral flow from this bottom blood supply coming up to the top. And you can see how sometimes that arcade of collateral flow could be disrupted if you make the tube too narrow. So again, in our practices, in thoracic surgery, there's a lot of debate about whether you tubularize, how narrow is the stomach, do you use the whole stomach? But I think you'll find the majority of surgeons now tubularize the stomach, because functionally it's better. However, there's some debate. And for example, in my practice, if I'm worried about the blood supply for any reason, the patient has bad calcifications in the aorta or things like that, I may tend to use the whole stomach and sacrifice a little bit of the emptying and issues. But if I have a standard patient with good anatomy, I'll tubularize. So some people are selective. Again, to impress the notion of this being a tissue transfer, when you do a colon interposition, which is probably the second most common conduit in replacement of the esophagus, again, we're depending on a blood supply from the abdomen to be able to perfuse this conduit, this graft, all the way up to whatever location we need it to reach. So being able to preserve the blood supply, which in the colon is the marginal artery, we need to be able to have blood flow, if we're going to use a left colon, to go through the left gastric all the way across the transverse colon to the hepatic flexure. And understanding this anatomy is critical. And then you can see that again, we're using the farthest piece of the colon from its blood supply in order to have the most important part, which is the healing of the new connection. Again, the jejunum is another conduit that we use. And in this circumstance, the vascular anatomy does not allow you to reach the neck without augmenting the blood supply. So you have to have blood supply from the bottom part, and then a free vascular anastomosis at the top in order to perfuse the distal part so you can reach all the way up to the neck. So you can see the higher you have to go, the more likely you're using more ischemic areas of the conduit, and therefore increases the risk of leaks, strictures, and complications. And so I really want to impress on you that a lot of the part of the operation that is tricky and that requires experience is how to harvest that conduit and how to protect it so it functions in the right way. So I'll take a minute to talk about esophagectomy techniques, because there are several and different people do different things. And again, I think for the non-surgeons, it might be unclear why we do one or the other, or which ones are why we do one or the other. So Ivor-Lewis esophagectomy is the most commonly performed esophagectomy, whether it's minimally invasive, open, hybrid. It's what most people do, and that's probably related to the fact that most esophagectomies today are being done by thoracic surgeons. If you go see a surgical oncologist with a GE junction tumor, you're more likely to either get a gastrectomy or a transhiatal, which I'll explain in a minute. So that involves a right thoracotomy and an abdominal approach, usually with the abdominal approach being done first, harvesting the abdominal lymph nodes, preparing the stomach for transfer, plus minus some kind of adjunct, including a feeding tube and a pyloroplasty or pyloromyotomy, and then turning the patient over, doing a right thoracotomy and doing an intrathoracic anastomosis. It is ideal for mid and distal esophageal cancers. And again, it's the operation that is most often performed by thoracic surgeons and often done in the country. A transhiatal approach, popularized in the thoracic surgery circles by Dr. Oringer, after it had sort of lied dormant for many years, involves the avoidance of doing thoracotomy. And so the entire operation is done through an abdominal and a neck incision. So this avoids the potential morbidity of thoracotomy. The dissection is done bluntly for the most part, although with robotic techniques and some minimally invasive techniques, the amount of blunt dissection can be minimized. It's ideally really suited for very low-grade GE junction tumors and benign disease, because a lot of the lymph node dissection is done bluntly. And so not that is a big problem from bleeding, although that can be a complication, but the amount of lymph nodes harvested in comparison to a transthoracic approach is often lower. And I'll demonstrate also that the oncological outcomes are believed to not be the same. And this is kind of what it looks like. Again, it's here's an abdominal incision, here's a neck incision, and here the graft, the stomach has been prepared as a tube, and then you can see how the distal part that's making the connection is surviving on that blood supply. This is a nice picture, better than one that I could find from the University of Iowa, but it really demonstrates what happens. Now that stomach is going to be tucked in the mediastinum, going in the esophageal route, and they will come out on this part to make the connection, but essentially that's what it would look like inside the body. Another common, not so common technique, but the next common technique is what's called a McEwen, a 3-hole or 3-field esophagectomy. And that involves a neck incision, a right chest incision, or an abdominal incision. Typically, most surgeons do the right chest first to mobilize the esophagus. And I think one of the advantages of a 3-hole is if you're worried about resectability of the tumor, meaning you're worried that's invading the airway or in the pericardium, or you're not sure if it's going to come out. I think it's, and that's in the chest where that region, that anatomy is in question. I think it's better to start in the chest, mobilize, figure out if it's resectable, as opposed to doing the entire abdominal component in an Ivor-Lewis, and then come to find out that you can't take the tumor, or the tumor is invading the airway, and you're not going to help the patient. And so I tend to use a McEwen when I'm worried about the resectability in the chest, or if I know I need a big margin and more than I can achieve with an Ivor-Lewis, and don't want to do a transhiatal. So most patients with more than mucosal disease in which I need to go high, I'm going to do a 3-hole McEwen. So it's then ideal for upper to mid esophageal cancers where you need a margin. However, the complication rate with a 3-hole is higher due to issues arising in the neck, which include incisions in the neck, which include recurrent nerve injury, aspiration, and then the leaks that are more common in the neck. And I'll go into that in a minute. So how do we decide which technique do we use? I gave you a little inkling into my thinking, but a lot of it sometimes comes down to surgeon preference. There might not be a reason other than that's the way I was trained and that's what I do. For me, a big question is it cancer? And if it's cancer, I'm going to do some transthoracic approach. And again, because I'm a minimally invasive surgeon, I have the ability to control a little bit the morbidity of the thoracotomy by doing things thoracoscopically. And particularly, I look at this data. This is a randomized trial looking at transthoracic versus transhiatal esophagectomy. And you can see that the survival overall was better with a transthoracic approach. And we believe that's because we do a better nodal dissection, better staging. The patients get the right treatment when we know what we're dealing with. Depending on what proximal margin you need to have might determine which operation you do. For example, if somebody has a lot of Barrett's up to 20 centimeters, you may want to do a 3-hole esophagectomy or a transhiatal so you can get enough margin. We talked a little bit about resectability. Again, I started in the chest if I'm worried. So I'll do a 3-hole there if I think I'm not going to be able to get it out of the airway or the pericardium or the aorta. But if I think it's a easily resectable tumor, my ideal is to do an Ivor Lewis. Again, the extent of nodal dissection, let's say you have a node in the cervical area in the neck, periesophageal node, you want to go get that. And so you might choose a 3-hole or a transhiatal in that case. And then what your preference is about a cervical interthoracic anastomosis. And I'm going to go into that in a minute. So again, this is sort of an algorithm from a program that sort of prefers to do Ivor Lewis, and you can see how they go through their cancer factors to then decide, how well the patient was treated, where is the tumor, and depending on those factors, they decide whether they're going to do an Ivor Lewis or a McEwen 3-hole esophagectomy. So one of the issues that is a determinant for many surgeons is whether they like doing a neck or a chest incision. And so I think it's good to review what our thinking is there. The advantage of a neck incision is that it's easier to deal with a leak theoretically. A lot of times, some of the leak will still go into the mediastinum and the chest, and we'll need drainage and management of that. But a lot of these leaks are in the neck, and therefore they're easy to manage with local wound care. There might be some better gastric emptying and less reflux the higher the anastomosis is. And people just think the conduit is straighter. The thoracic inlet may provide an anti-reflux valve. And so some people think that, and there's some data to suggest that the functional outcome is better the higher the conduit is anastomosed to the esophagus. Again, it allows for a transhiatal approach, and it gives you longer margin. The disadvantage is that the leak rate and the stricture rates are higher in the neck. You need more conduit to reach. So if you have a conduit issue, you may have to do an anastomosis in an area of the stomach that you don't want to. And then lastly, the incidence of recurrent nerve injury is higher when we're in the neck. Now, a lot of surgeons have modified their techniques and experimented with their techniques to lower this disadvantage rate. For example, Dr. Oringer has developed an anastomotic technique that has really improved the stricture and leak rate. But in general, most people feel that the trade-off here is easy management of a leak, but a higher leak rate and stricture rate. In the neck, the advantage is that the leak rate is lower because you can avoid using ischemic parts of the stomach, and also the stomach is under less tension. And so, so that allows for better healing. And again, it avoids the neck incision and the potential for a higher recurrent nerve injury. However, when you have leaks in the neck, the management is more challenging. And again, you may be limited to some extent by the proximal margin. So if you weren't prepared to go to the neck, you may find yourself either really tight or perhaps sacrificing a few centimeters of margin to get it done through the chest. So that's sort of the decision-making that undergoes there from the surgeon perspective. Now, when you look at what's happening out there and what are the changing paradigms, well, you can see that the use of Ivor Lewis, so when we look at NISQIP hospitals, the utilization of Ivor Lewis has increased, and the utilization of transhiatal has decreased. And I would say that the McEwen is essentially the same. And I think there's two reasons for this. One is the data I showed you about better outcomes in cancer with a transthoracic approach. Also, with the changes in training, the increasing subspecialization, most general surgery programs are not exposing their general surgery applicants to the volume of esophageal surgery that they used to. So you can see just in a relative percentage here from starting point in 2007, the amount of general surgeons that are performing esophagectomies has decreased, while the thoracic surgeon has been taking over more and more of that care. And I think that's just a reality of training and how subspecialized care has really taken over. Also, how general thoracic surgeons have been increasing in numbers and making their livelihood and their expertise and professionalism on esophageal surgery. So, and again, here you can see though that even though we have changed the parameters, we're also getting a lot better at dealing with our complication rates. So for almost all the procedures that are being done, we have been able to work on these procedures to try to improve our outcomes and the complications associated with them. And so that's one of the roles of minimally invasive surgery. Why do we go through this process of changing an operation? Is to have better outcomes. We know that patients that do well with surgery and have minimal complications not only do better and allow them to get their multimodality therapy, but their surgical oncology outcomes are improved. And although many view esophagectomy as palliative and they're hesitant to refer patients, they do it because they're worried of the complications. And so we strive to do better. There are many techniques that are out there. I'm going to skip a couple of slides, but I'll kind of show you our technique. We do an abdominal minimally invasive Ivor-Lewis approach in most of our patients. This is the port placement that I use. It's very similar to the UPMC technique where I was trained in part to do this operation. Again, we mobilize the stomach, do the regional lymph nodes, preserve the blood supply, mobilize the stomach. We want to make sure the stomach can easily reach the hiatus, the pylorus. That creates a tension-free approach. We create the gastric conduit and tubularize. We do a jejunostomy and plus minus a pyloroplasty. So this is sort of how we do the conduit. You can see we tend to do a 4 to 5 centimeter conduit with staplers and sort of tubularize this, and that extends the length of the esophagus. And then we suture it to the remaining gastric specimen, and that allows us to transfer it up to the chest. In the chest, these are our incisions, including an accessory incision to remove the specimen and place the EA stapler for anastomosis. And in the chest, we complete a complete mediastinal dissection. We mobilize the esophagus. We do a high intrathoracic anastomosis, typically with a circular stapler. A 28 millimeter EEA, I think, is ideal. It gives you good aperture and also gives enough tissue in the stapler that I think you are more likely to get complete donuts, and the surgeons will know what that means. When you do your anastomosis, sometimes with a 25, you get a little skimpy on the rings. And so I try as best as I can every time to at least get a 28. And that's the technique that we use to create our intrathoracic anastomosis with a circular stapler. The anvil is sutured to the esophagus. The stapler is delivered through a gastrotomy in the part of the stomach that is well perfused. So this gastric tip that is ischemic, we try to avoid using it as best we can, trying to stay within a few centimeters of the pedicle, make the stapler, fire it, create a new anastomosis, and then get rid of the ischemic part of the stomach. So a couple of things about drainage and adjuncts to esophagectomy, whether to drain the pylorus or not, to do a pyloric drainage. And there are a lot of options here. The reason it's a problem is because by denervating the stomach, we may be causing delayed gastric emptying, which is a problem with esophagectomy. So the options are to do nothing, just make a nice straight conduit and see if it works, and if it empties well, great. And if it doesn't, you can dilate the pylorus or do something afterwards. Pyloromyotomy or pyloroplasty, where you actually disrupt the pyloric muscle. Some people inject Botox. Some people just let it see what happens and either do a postoperative balloon dilation or endoscopic myotomy. The data is really inconclusive. I think the trend has been moving away from doing definitive pyloric drainage procedures for two reasons. I think one, it's time consuming sometimes. And number two, I think one of the side effects is potentially bowel reflux, where you get a lot of bilious refluxate into the gastric conduit that the patients can sometimes feel, swallow, and regurgitate. And also dumping is more common when you do a pyloric procedure. So I think the trend is moving away from it. Also, another thing that we used to do religiously all the time, and the national trend is moving away, is from a jejunostomy. The thinking has always been that you want to let the esophagus rest while it's healing, and yet you want to supplement the patient to allow everything to heal. And so I think the data would suggest that most patients do not need it, but it's really hard to predict which ones will. And so it's a nice safety to have it. However, they can be associated with complications, bowel obstructions, leakage in the skin, and irritation of the skin. And once the patients get discharged, it's very unreliable how well they use it. So several recent studies have suggested that the outcomes are not affected either by preoperative or postoperative jejunal feeding, and should be used selectively as opposed to categorically in every esophagectomy patient. Respiratory, some of the complications with esophagectomy that are important to recognize, I think respiratory failure and pneumonia are the most common. They're greater with the thoracotomy and transhiatal approach, and greater with open rather than minimally invasive surgery. And it's associated with aspiration, which can either happen intraoperatively due to delayed gastric emptying or pharyngeal aspiration of recurrent nerve injury. So this is one of our biggest issues that we have to work on. And in fact, Dr. Moorman has been working on a quality improvement project and a study looking at minimizing aspiration risk by controlling the mouth flora and dental hygiene of our patients before they undergo thoracic surgery. And we're hopeful to get some results of that pretty soon. But it's a big problem that we need to, that we encounter and are taking efforts to try to minimize. The anastomotic leak rate sort of is somewhere between 1 and 15%, on average about 5%. And it's most commonly an ischemic complication that can sometimes present weeks after surgery. Typically, if somebody leaks within the first couple of days, it's a technical problem. But in most patients, it's an ischemic problem that takes some time to develop. It tends to be associated with a deep space infection or empyema, and the mortality used to be as high as 20%, but really has decreased significantly as we've become better at managing these endoscopically and with interventional radiology and minimally invasive drainage techniques of the infection, where even though none of us want to get leaks, and leaks are bad and may have some impact on the long-term oncological outcome, the management of them has become a lot simpler and the mortality a lot lower. And so we've made great strides in at least minimizing the incidence and also minimizing the impact on the patient's survival. Anastomotic strictures occur about 5 to 20%. And again, they're more common in patients with neck anastomosis. And if you have a leak, when a leak heals, well, one, it was for ischemia. So again, it's usually an ischemic complication as well. But when it leaks and it heals, it scars. And therefore, that's what causes that stricture. It tends to respond well to dilation, and self-dilation is an option for patients that have recalcitrant strictures. Although I would say the majority of patients require a few dilations and typically will stabilize to a point where they don't need repeated dilations. Very rarely you might require an operation. Just a few weeks ago, we did an operation kind of like a pyloroplasty for somebody with a stricture and a neck anastomosis, and it ended up working really well. Somebody that was getting dilated every 2 weeks and couldn't do self-dilation. So chylothorax, again, is another complication, and it's related to the proximity of the thoracic duct to the esophagus. That's a lymphatic leak that can actually be really devastating for patients and can have serious effects, not only the loss of nutrients, but the loss of lymphatic fluid. In general, we can manage low output chylothorax with diet modification, but if it's a high volume chyle leak, which can be anywhere between 1,000, 1,500, 800 cc's a day, the likelihood of non-operative management is low in that to resolve. And so we tend to operate early or embolize the thoracic duct early. That depends a lot on the expertise of your center. Here's an example of a mass ligation of a thoracic duct, basically taking all the tissue in the mediastinum between the esophagus vein and the aorta and ligating it. And that tends to give a pretty good result with a postoperative chyle leak. Delayed gastric emptying is another really annoying complication of this operation, because sometimes you can do it all right, and just the way the stomach functions, it won't empty. It can be done to a neurological issue and lack of motility in the esophagus, where it only empties by gravity. And if that's the way the esophagus is, if it's baggy and it's not peristalsing, then any kind of twisting in the esophagus will lead to decreased drainage. So if the pylorus is kinked or in high tone, if you get a redundant conduit with what we call a transverse shelf, where the stomach almost has to do a U-turn to get out of the chest, all those patients do badly. And then periconduit hernia, which is an increasing problem with minimally invasive surgery because there's no adhesion. So this is an example of bringing up too much stomach, and therefore you get this transverse shelf. You got to be real careful about how much stomach you bring up so that you don't have redundancy. This is a problem that can be fixed surgically if needed. Here's a problem where the stomach is spun around, so it's spiraled. Usually this part of the stomach should be on the left side. And so if the stomach twists, it creates a point of obstruction at the hiatus. And that can be not only a problem for delayed gastric emptying. If it's really bad, you can get death of the stomach. And then paraconduit hernias, where abdominal contents go through this hiatal hernia that we've created to bring the stomach into the chest. And because in laparoscopy, there's less adhesions, it's more likely to then develop this paraconduit hernia, can lead to some obstruction. Thankfully, this is usually correctable with laparoscopic surgery, and the incidence of serious problems is pretty low, but it's something that we have to work on as surgeons, because we're seeing it more often as we do minimally invasive surgery. So I'll wrap up just to talking about mortality and outcomes. One of the great things that I can say is that the overall, the mortality of esophagectomy has really decreased. It used to be that the mortality was somewhere between 10 and 20%, depending on where you read. And if you look at this example, this is outcome data comparing the outcomes of esophagectomy between the national inpatient sample, which basically looks at a sample of all care in the United States, outcomes on NISQIP, which is the American College of Surgeons Quality Initiative database, and the General Thoracic Surgery database, which is a more specific thoracic surgeon database. And you can see that all of us are doing better, but there is a difference between the national statistics and the statistics at programs that participate in NISQIP and the General Thoracic database. And that's something that has panned out year to year. And although the difference is getting smaller, it seems that for some reason, places that are part of the General Thoracic database do better. And that's likely because there are general thoracic surgeons that are really focused on esophageal care, taking care of these patients, I would argue. And so the other piece of it is the oncological results. So how good is esophagectomy at treating cancer, and what's its role in the management of esophageal cancer? And I would say that I think the oncologic and long-term survival contribution of esophagectomy, I don't think is well understood. I think we know very well that esophagectomy establishes the best local control and the best palliation of symptoms. However, what is the role oncologically, and how much better patients do adding esophagectomy to standard chemoradiotherapy for bulky tumors? It's really not well understood. I struggle to tell patients. I think it adds some percentage of survival, but it's not dramatic. It doesn't take patients with stage 3 esophageal cancer from 30% to 50% or 100% survival. It's much more, the margin is not that significant. And so in esophageal adenocarcinoma, it remains a standard of care to use trimodal therapy compared to bimodal therapy, but several groups have talked about using a more selective approach because it's, again, unclear what the benefit might be. In squamous cell cancer, there's actually been 2 randomized trials that have looked at the role of surgery added to chemoradiotherapy, and they show no long-term benefit, but they're small trials with some inclusion and exclusion criteria that don't apply to all places. And so it's a very debated question in our specialty, what the role of esophagectomy is in squamous cell cancer. Again, because squamous cell cancers tend to be higher in the neck, in the chest, and in the neck, so the surgery is more complicated. And the consequences of either operating or not operating and dealing with a recurrence are very high. So we don't have consensus in the best way to treat squamous cell cancer with surgery. Now, I'll finish up with the volume outcome relationship, and just to say that there's a lot of work out there trying to figure out where the right place to have an esophagectomy is. And it's a really complicated issue with a lot of challenges. Clearly, volume and experience are metrics that correlate with improved outcomes, but it's not clear if volume alone is the metric, or is there a surrogate for other factors that are important. For example, if you look at programs that do esophagectomy at a low volume, but at a place that does abdominal transplants, liver transplants, it negates all the volume outcome. And you could imagine the resources that a hospital has to deal with the complications and the problems and the kind of surgeons and GI groups that are associated with a liver transplant program probably means that you're at a high quality place and volume doesn't matter. So some people have quoted as volume is important, but is not ready for prime time. However, if you look at Leapfrog and other hospital safety groups, they are putting standards out there for us to have minimum standards to perform complex surgery. And I think that this is a good discussion to have. You know, for esophageal surgery, for example, they're looking for hospitals to do at least 20 cases a year, and for each surgeon to do 7 minimum. But if you go to a place like Mississippi, I mean, that could be challenging in some years for us or other programs to be able to provide the care. And is MD Anderson or Memorial Sloan Kettering going to take our patients without insurance to get their esophagectomies there? So it's a real complicated issue that I think we haven't thought out completely, but it's something that everybody should be aware of. I think figuring out what is a high quality program is perhaps more important than the number of cases. So you do want to have a program that's doing esophageal surgery. You want to make sure that the surgeons are knowledgeable, they have experience and training, because one of the issues that we can get is the failure to rescue. And that is what I think experienced centers and high quality programs do. They recognize complications and they deal with them. And it's the failure to deal with complications that deals with mortality. You want to see a program that has multidisciplinary management teams, tumor boards, and good GI and surgeons working together to deal with the problems that can arise. You want to have great critical care resources. For example, Dr. Mormon published a paper on us using ECMO to salvage a couple of patients with bad respiratory failure. And so you need strong GI and radiology services to partner with you to have a good high quality program. And then you want to work on patient care pathways, enhanced recovery pathways that look at your preoperative, intraoperative, and postoperative care to try to make sure that you're doing everything you can to minimize morbidity. I think the volume outcome relationship is difficult, and although it sounds like good policy, is very difficult to implement. Here's an example looking at the number of programs how many cases they do. And you can see that the vast majority of programs in the genothoracic database are doing less than 15 esophagectomies per year. And you'd be there's only one doing 200, here's 150, maybe there's 5 programs, and you see how quickly and exponentially it decreases. And so where the right place to be here is really hard to know. And again, here, this highlights how good outcomes can be achieved by low volume programs. Here are a number of programs that are low volume that are achieving 3-star quality scores for esophagectomy, but we see some high volume ones over here. You also see some 1-star programs here in the low volume as well. So I just don't think that volume as a single measurement is ready for prime time. I think Leapfrog has probably jumped the gun a little bit. However, I think it's important to recognize what a high quality program is, and that's where the patients need to go. We have to have access with high quality, and I don't think we've done enough in our policy to sort of assure that. So I think the use of volume is premature, but I think almost every sort of region will have a center that can achieve high quality outcomes. Here in the Deep South, you know, we have us, there's the programs in New Orleans, in UAB, in Ochsner, so they're within driving distance. And so I think that patients may not be able to get a good esophagectomy in the Mississippi Delta, but they don't necessarily have to go to New York City to get a good esophagectomy. And so that's something that we're going to have to wrestle with and think about, but I think it's important to recognize that relationship. So ongoing efforts to improve care. We talked about enhanced recovery pathways, better risk assessment, figuring out frailty and sarcopenia, intraoperative assessment of conduit perfusion. We're using dyes to figure out what parts of the stomach are good and not, the use of robotics, measurements and tracking of quality of life. And we need to do more randomized trials on the specific components of the esophagectomy to get down to a standard. I think that would be great. And for example, in Pittsburgh, they're testing the randomized trial of using a narrow conduit with a pyloroplasty or not, try to figure out what works better. And I think those are the kind of trials that we need to be doing at academic centers to really figure out the answers here. So with that, I'll finish. I know it was a lot. I hope this helps a little bit sort of clarify esophagectomy, its role, how we surgeons think about it, and how I would like our gastroenterologists to understand the procedure and its role in the management of esophageal cancer.
That was great. Thanks a lot, Dr. DeDalva. I think you hit a lot of points, and I'm glad that this is recorded so we can go back and look at it. We got one question from the chat room about if a patient seems unmedically fit for an esophagectomy, should a surgeon still be a part of the conversation, or should that person still be evaluated by a surgeon, and what your thoughts are on that?
Yeah, I mean, I think whether it relates to, I think for any kind of surgery, and in particular with surgeries that have a big impact on functional outcome, I believe the surgeon is the best determinant of operative candidacy. I think we know what we can do. We know what our institution can do. And we have the right level of assessment and risk. Sometimes is the opposite way. Some people have the courage of the non-combatant and say, oh, that patient can have a resection. And you're like, are you crazy? And sometimes there's a patient that may have bad PFTs, but is a construction worker and they've been turned down for surgery, and they're totally reasonable. So I do think that the surgeon needs to be involved in the process of decision making. And from the beginning, I think it's better for us to see the patients before they get chemoradiotherapy than to have them be treated, maybe incompletely staged, not have a good understanding of the tumor anatomy, its relation to the stomach and the GE junction, for example. That's one of frequent frustration for me, where I can't tell how far the tumor was in the stomach. And so I think the surgeons need to be involved. I think unless there's clear metastatic disease, I think we need to be part of the multidisciplinary team that makes the decisions about surgery, EMR, ESD, ablation, surgery, candidacy for surgery, preoperative treatment, chemoradiotherapy. I think it takes a team. Now, I do think that the best decisions are made in a multidisciplinary approach. So having the input of the team is important. But I think the surgeon needs to be in the middle of the decision making about who's a candidate for surgery and not.
Sure. And I think one of the other questions was that the conversation circling around G tubes and J tubes, I think they've probably been around since esophagectomy's been around. Has your practice transitioned towards getting away from J tubes? And then also, would a patient that already had a G tube placed, would you consider doing an esophagectomy on them, considering the conduit you would be using?
Yeah, that's a good question. I think for a long time we have been paranoid about tubes in the stomach, and there's two issues there. One, now there's a new staple line or a new suture line that has to heal in an ischemic conduit. And number two, particularly with PEGs, there is a concern that that depending on the placement of the PEG, it could be in a suboptimal area or across the gastropaploic arcade, which is what gives the blood supply of the stomach going up to the chest. And so the data has suggested that for the most part, putting a PEG does not affect outcomes for esophagectomy. So that's number one. So I think we are fine with somebody having a G tube and then us proceeding to an esophagectomy, taking down the G tube in the operating room. We have not had any leaks or any problems with that, and never seen a PEG really go through the gastropaploic arcade, although it's been described and people have anecdotal reports of that. I think if you have somebody with a G tube, you have to be prepared, if you don't have an alternative conduit strategy, to back out and then regroup if you see the gastropaploic arcade is involved. And so as far as preoperative J tubes, our utilization of preoperative J tube has gone down a lot, because I think that most patients that have dysphagia can swallow liquids and therefore can do boost and protein shakes. And the majority of them will get better as they start their chemotherapy and radiation. So I think even though it saves kind of a step, it segments the operation by doing the J tube before, and then you don't have to do it when you come back for the esophagectomy. I think the data would suggest that, one, it only helps people that are really nutritionally deficient, and two, that when you put a J tube in people, the majority of them don't use them the way you expect them to. So that the efficacy, the real world efficacy, is not great. And so we use them very selectively in the preoperative period. We still use them in the postoperative period a lot. So I still put a J-tube every time. I've been thinking about backing away, but I just haven't pulled the trigger yet. But I'm getting there, because I think the data is suggesting that it makes it a lot simpler. It saves you 20 minutes, half an hour of the case. Anything that makes the case go a little longer not only benefits the team and the surgeon, but I think benefits the patient. So we really have to answer and know whether these adjuncts really add something, you know? And
Sure.
so we're asking those questions. So I still use a J-tube postoperatively, but I'm starting to think about backing away.
That's great. Yeah, it's we've all had patients that were happy that the J-tube is in when we need them, though.
Yeah,
for sure. And then briefly, do you have any restrictions on radiation dosages pre-op, and then also nutritional parameters that a patient would need to meet before you would consider for the esophagectomy?
yeah, sure. I think that the treatment with radiation for surgery is pretty well established, and that's 50.4 gray of radiation. I think if you, and I think we know that in general, 60 gray is about safe. So if somebody's between 50 and 60, that's fine. Some centers give a little less than 50 if they're going to have surgery. But I think I have not encountered a lot of patients that got over 50 gray of radiation. I think that practice is pretty established. So in my mind, I don't have a definitive cutoff, because I just don't see patients getting bad radiation for their treatment. And so that's one part of it. What was the second part of your second question on that?
Nutritional parameters that patients would need to achieve.
Sure. I'll say one more thing about radiation, which the other important piece for perhaps the non-surgeons to recognize is that the time between finishing radiation and doing surgery is important to us. We do want to have a period of the patient recover between the chemoradiotherapy and their operation, but we don't want that time to be 6 months, 9 months, 10 months, because the effects of the radiation increase over time, and the fibrosis and vascular changes increase over time. So some surgeons like to operate the patient within 6 weeks, some 4 weeks, some within 3 months. I think anywhere between 4 weeks and 3 months is very reasonable. But when you start getting 6, 12, 8, 9, 12, a year out from the treatment, that's when you start getting in the salvage setting. And then the salvage esophagectomy complications are higher. As far as nutrition, we want patients to be feeling better, to be in an anabolic state, not a catabolic state. And so we look at our albumin, and in general, an albumin greater than 4 is associated with good outcomes. I'm okay if they're sort of eating better, putting on muscle mass, and they have an albumin of 3.5. I'll proceed. But if they're less than 3, I'm going to hold off until they're bulking up.
That's great. Well, I don't see any other questions in the chat room. I would just give a reminder to people to email Dion if you want CME credit for this, so that we have your information. Otherwise, that was a great talk.
Well, thank you for hosting, Tyrone. It's great to get you looped in on this. Now you're in the loop, so we're going to call on you again.
Excellent. Sounds good. Good seeing you guys.
Great. Thank you, everybody. Thank you for your attention.
Bye-bye.